Okay. Okay, so we're gonna get started, guys. This is the last tutorial for the course, so congratulations on making it this far. Today's tutorial, we're gonna be talking about Parkinson's disease. It's not a super long tutorial, and once again, the assignment is pretty straightforward, so it shouldn't be too difficult for you guys. Also this week, the tutorial recording is going to be posted on YouTube by Nick Antony, and then you guys will get the link because we ran out of space on Canvas. Okay. So we're going to be talking a little bit about the clinical profile and description of Parkinson's, as well as the pathophysiology. We'll talk a little bit about the biomarkers and the therapeutic approaches as well. So just a little bit of history. Parkinson's was coined and discovered by a man named James Parkinson in 1817, who was an apothecary surgeon. And he wrote an essay on what he termed the shaking palsy. He described it as paralysis agitans of observations he made in 6 individuals while he was just walking around the streets of London during his normal day. So Parkinson's is characterized by a tremor at rest. The tremor is about 3 to 5 hertz. So that's a frequency, so about 3 to 5 tremors per second. There's also this effect of pill rolling, which we'll talk about a little bit later. They do have very slow movements, particularly when starting, and they have short, very rapid steps. So what we're going to do is watch like a quick 30-second dramatization of a gait demonstration of Parkinson's. Hopefully this doesn't lag
gait that is hypokinetic gait. The prototype is Parkinson's or Parkinsonian type of gait, in which the patient will have a posture which will be stooped over, leaning forward, and then will have difficulty as far as initiating gait. When the gait is initiated, there are small steps. Oftentimes there's a tremor associated with this. And as the gait progresses, there may be a picking up of speed, or what's called a fenestrated gait. And then in turning, instead of having the normal turning, the patient will turn en bloc, which means they'll turn almost as a statue moving around. And then again, having difficulty starting and the marche petit pas.
So that's essentially what a Parkinson's gait would look like. If you want to watch that again, the link is in the slides. Yes. Okay. So this is the basal ganglia, which you guys were able to label and stuff in like the first week of this course. So the basal ganglia are a collection of nuclei found on both sides of the thalamus. They're outside and above the limbic system, but below the cingulate gyrus. So they're kind of contained within that temporal lobe area. So glutamate is the most common transmitter here, just as everywhere else in the brain. But the inhibitory neurotransmitter GABA plays the most important role in the basal ganglia. So that's GABA, G-A-B-A. The largest group of these nuclei are called the corpus striatum, which are the striped body, which is made up of the caudate nucleus and the putamen. You can see those all labeled in this picture. The caudate nucleus is shown in yellow. The putamen is in green. And there's also the globus pallidus and the nucleus accumbens. So the globus pallidus is shown in this dark red and light pink. So it has an external and internal segment. But this whole region here is the globus pallidus. So yes, all these structures are double ones. So they are occurring on both sides of the brain. So you can see in this image, we have the basal ganglia on this side, as well as the basal ganglia situated on this side. So the substantia nigra is kind of like an associative structure with the basal ganglia. And it's a pair of plate-like structures that are located anterior to the red nucleus. So you could see in this image here, the red nucleus is this big red circle, and the substantia nigra is this highly pigmented stripe area within the or near the basal ganglia. It gets this kind of pigmentation from neuromelanin, which gives it a very dark appearance. And all of the neurons within this substantia nigra region are dopaminergic neurons, and they project to the striatum. So they project to the basal ganglia. So this structure is really important in understanding the pathophysiology of Parkinson's disease. Okay. So there's different portions of the substantia nigra, which I won't really get into too much. But the ventrolateral portion is the pars reticularta, and the dorsomedial portion is the pars compacta. You don't really need to memorize that, but if you see that in diagrams, that's what that means. It is cell sparse. So this means that the cells are present and they're very clustered, and they're mainly GABAergic cells. So they respond mostly to that inhibitory GABA neurotransmitter. The substantia nigra have connections with the cerebral cortex, the spinal cord, and very, very extensive reciprocal connections with the basal nuclei, or the basal ganglia. So reciprocal connections is they're sending signals to the basal ganglia, but also receiving them, okay? Okay, so can anyone tell me what the difference is between hypokinetic and hyperkinetic disorders? Yes.
It sounds like one inhibits movement while the other kind of causes uncontrollable movement.
Exactly. Yes. So hypokinesia refers to decreased body movement. So it's associated with basal ganglia diseases like Parkinson's disease, which we're talking about today, as well as mental health disorders and prolonged inactivity due to illness. Hyperkinesia refers to an increase in muscular activity that results in excessive abnormal movements, excessive normal movements, or a combination of the two. So the role of the basal ganglia in these diseases are kind of, it's like a filter. So excessive inhibition results in a hypokinetic disorder, where not enough inhibition results in a hyperkinetic disorder. So the basal ganglia is really important for regulating and coordinating smooth movements, both in initiating movements and maintaining them. So almost every single motor command sent down from your brain travels through the basal ganglia before it goes to the effector muscle. So if you have a disorder in the basal ganglia, it's likely that you're going to see some movement type symptoms. As for the chart, I have it here. So there's a couple different diseases on here. So under hypokinetic, you can see Parkinson's disease, and this is the most common basal ganglia disorder that interferes with both voluntary and automatic movements. On the hyperkinetic side, we have a lot more. So there's Huntington's disease, which is an autosomal dominant hereditary disorder. This causes degeneration in a lot of different areas of the brain, but most prominently the striatum, which is part of the basal ganglia, and the cerebral cortex. So one of the signs of this disease is chorea, which is essentially abnormal involuntary movements and dementia, or Huntington's dementia. Another really popular hyperkinetic disease, or well-known, I should say, is Tourette's disorder. So this can cause both vocal and motor tics and involves very abrupt, repetitive, and stereotyped movements. And many people with this disorder are aware of nearly just these irresistible sensory urges that precede the tics. So they're actually able to tell that a tic is coming, and it can be very painful for them to suppress these types of responses. Things like stress, emotional excitement, and fatigue can exacerbate the tics as well. And tics can be temporarily and voluntarily suppressed, but the urge to tic will build during suppression, which leads to that painful response. Cerebral palsy is another one. So this involves chorea, which is abrupt, jerky movements. There's also slow, wreathing, purposeless movements, and it's associated with lesions involving the basal ganglia as well as the ventrolateral thalamus, which is the motor area of the thalamus. So I just have a case study question up here on the board. So a patient age 62 years old is first presented with weakness in her right hand. Does someone have a question? Okay. Her weakness progresses, resulting in her being unable to hold things like plates or glasses without dropping them. And her symptoms progress to a tremor. Upon testing, she is diagnosed with early stage Parkinson's disease. So, what is the main pathological cause of Parkinson's disease? Does anyone know? We haven't really covered it yet, so that's okay. So the main pathological cause is death of the dopaminergic neurons in the substantia nigra, as well as acetylcholine-producing cells in the pedunculopontine nucleus, or the PPN of the brain. So this is a result of oxidative stress, mitochondrial dysfunction, and programmed cell death that has both genetic and environmental factors. So dopamine, if you don't know, is the site of action. It works in the basal ganglia, and it works with goal-directed behavior. So it helps with control of movement. So if we don't have those dopaminergic neurons, it's really hard or impossible for us to control our movements. A dopamine from the substantia nigra to the striatum adjusts the signals to the output nuclei, and the output nuclei's job is to provide the appropriate level of inhibition to the target. So if they're inhibiting too much, you'll have those hypokinetic disorders, and if they're not inhibiting enough, you'll have the hyperkinetic disorders. Stimulation of the pedunculopontine nucleus regulates contraction of the postural and girdle muscles. And with the death of these neurons, we have loss or a problem with all of the above functions, any function that the striatum, the basal ganglia are responsible for. Okay, so Parkinson's disease is the most common basal ganglia motor disorder, a hypokinetic disorder, as we saw from that chart. And it has 3 subtypes. So there's akinetic or rigid, which is about 50% of people diagnosed with Parkinson's. There's tremor dominant, which is about 40%, and then a mix of akinetic and tremor dominant features. So Parkinson's disease is chronic and progressive, meaning that symptoms will continue and worsen over time. Once you're diagnosed with Parkinson's, you cannot revert back to any previous stage. We'll talk about the stages in a couple of slides. Nearly 1 million people in the US currently are living with Parkinson's disease. The cause is unknown and there is no cure, but we do have treatment options like medication and surgery to just help mitigate the symptoms. Parkinson's involves the malfunction and death of vital nerve cells in the brain, so the neurons. It primarily affects the neurons in the substantia nigra, and a lot of these dying neurons produce dopamine, which is a chemical that sends messages to the part of the brain that controls movement and coordination. So as Parkinson's progresses, the amount of dopamine produced decreases, leaving a person unable to voluntarily control their movement. So there's a specific group of symptoms that individuals experience. It varies from person to person, but the primary motor signs include a tremor. So this can be in the hands, arms, legs, jaw, and face, bradykinesia, or very slow movement, rigidity, so stiffness of the limbs and trunk, and postural instability. So that's impaired balance and coordination. So in that video, we kind of saw that man shuffling forward. He was leaning over. He had a tremor in his arms. He was moving very, very slow, and his torso was completely rigid. So that's pretty classic of Parkinson's disease. So the hallmark of Parkinson's pathology is these Lewy bodies found in the dopaminergic neurons. So a Lewy body formation has been considered to be the marker for neuronal degeneration because neuronal loss is found in the predilection sites for these Lewy bodies. So to date, more than 70 molecules have been identified in these Lewy bodies, including alpha-synuclein, which is a major constituent of these Lewy bodies. It's abnormally found in 10% of pigmented neurons, and the substantia nigra contains a very large portion of these pigmented neurons, and more than 50% of those in other areas of the brain. So recent studies have suggested that different oligomers and protofibrils of the alpha-synuclein are cytotoxic, and that these may represent a cytoprotective mechanism as well in PD. So Lewy bodies can also occur in other diseases, especially diseases with dementia, like Huntington's disease. But you can see them here in this slide. So they're all of these very dark red areas in the brain. So the one on the left shows a Lewy body of the substantia nigra in a Parkinson's disease patient. On the right, those Lewy bodies are actually in the cingulate gyrus in a Parkinson's patient. So they can be pretty widespread throughout the brain. So symptoms start to appear in Parkinson's when most of the substantia nigra neurons are lost. So between 50 to 80% of neurons have died off. Most people lose these dopaminergic neurons throughout life. So just as you grow up, your neurons kind of slowly die off or become less useful. But in Parkinson's disease, these patients lose substantially more. So the remaining dopaminergic neurons can form additional sprouts, which may partially compensate for the loss, but they can never truly grow back. And like we said, Parkinson's is progressive and degenerative, so it's going to continue to cause damage in the brain. So most cases of Parkinson's are unexplained, but there are a couple running theories as to what could be going on. So one of them is that the dopaminergic neurons may be selectively vulnerable because the cell body has to maintain really large amounts of axoplasm and presynaptic proteins. Another is that they may just be selectively vulnerable because dopamine is very highly reactive. So that's with this whole biochemistry, the oxidative stress in the mitochondria type of hypothesis. In 2011, there was a paper that suggested that exposure to certain pesticides can increase your risk for Parkinson's disease. The term the frozen addict came out a while back, which essentially was associated with an impurity in synthetic heroin. So heroin users that use this synthetic heroin had it taken up by the dopamine transporters, and it killed off their dopaminergic cells in the brain. And then another is encephalitis. So in 1918, there was a worldwide pandemic of encephalitis, and it killed about 20 million people. And people who survived did experience selective damage to the dopaminergic neurons. They think that presumably some type of autoimmune reaction was provoked as a response to the encephalitis, but it's really unknown. So again, there's some genetic factors, some environmental factors. No one's really sure the exact cause, and it can be different for everyone. So this is actually one of your tutorial questions, so I suggest getting this stuff down. So list some of the signs and symptoms of Parkinson's disease. So one of the main psychological symptoms is depression. Cognition-wise, dementia is very common, and psychosis as well late in the disease. So these are hallucinations. In terms of consciousness, Parkinson's can alter the sleep-wake cycles and cause very excessive daytime sleepiness. In terms of the sensory or perceptual symptoms, they experience these visual perceptive blocks. So their movement slows or stops in response to nearby visual stimuli. So if you were walking through a doorway and you had Parkinson's, you might see the threshold of the door and freeze there for a moment, unable to kind of process what's going on before you can actually move through the threshold. This can be said when you encounter other objects like a shelf, or even walking past people in like a hallway or a store. The autonomic symptoms include constipation, orthostatic hypotension, thermal dysregulation, and bladder and sexual dysfunction. So pretty much anything that has a motor component can be affected by this disease. And then in terms of the motor symptoms, which are the most common symptoms that people associate with Parkinson's disease, are hypokinesia, so slow movement, rigidity, stooped posture, shuffling gait, difficulty initiating movements, both turning around and stopping, a resting tremor, those visual perceptive blocks, freezing during movements, and an inability to control your posture. So when you're answering this question, when you list the signs and symptoms, try to list some from different like categories. Don't just give me like 5 of the motor ones. Try to list a couple of different ones. So this is, again, just breaking down that previous slide. So it's divided in between motor and non-motor symptoms. So the motor: tremors, bradykinesia, rigidity, postural instability, shuffling gait, like we saw in that video. Non-motor symptoms include neuropsychiatric symptoms like dementia, declines in cognition, depression, anxiety, psychosis, apathy, sensory as well, like paresthesias, pain, sleep disturbances, So RBD is rapid eye movement behavior, and RLS is restless leg syndrome. So both of those can affect your sleep, as well as sleep apnea, sleep attacks, insomnia. There's autonomic dysfunction, fatigue, weight loss. There's a ton of different symptoms for Parkinson's, and they're pretty individual for each patient as well. So the main region that's affected, again, this is on your tutorial assignment, is the basal ganglia nuclei. Specifically, it's the neurons in the substantia nigra, okay? So we do have treatment options, even though there is no cure. So we do have drugs that can replace dopamine, like levodopa or L-dopa, which after being administered to the patient is converted to dopamine in the brain. And this remains the gold standard for treating Parkinson's patients. There's some invasive procedures like deep brain stimulation, neuronal transplantation, and destructive surgery, as well as rehabilitation, like physical or occupational therapy, which can improve mobility and functional status in individuals with Parkinson's, as well as intense resistance training to produce better muscle function than standard exercise can. So the gold standard for treating Parkinson's is this L-dopa drug, which remains effective only as long as there are sufficient dopaminergic neurons in the brain that remain to take up and use this drug. So this drug isn't dopamine. It's a chemical that once your dopaminergic neurons absorb it, can be converted into dopamine. So if you don't have these neurons to convert it to dopamine, then it's not really going to work. Some symptoms of this drug are dyskinesias or bad movements. So this is very common in people who have used L-dopa for many years. So the medicine can actually cause tremors as well, and it does have an effective window. So when you take it, there will be a certain amount of time where it's super effective, but before and after that, it's not going to be doing as good of a job. The mechanism is unknown, not really sure. They think it could be the continued activation of GI-coupled pathways. Other symptoms include visual hallucinations or psychotic symptoms like sleep disturbances and confusion. And there is this on-off phenomenon, so a very abrupt and transient fluctuation in the severity of Parkinsonism. Parkinsonism is just a demonstration of symptoms associated with Parkinson's. So this can occur at different intervals during the day, and these fluctuations are unrelated to ongoing drug dosage. So even though we can treat it, there's still not a whole lot we can do other than try to help make the symptoms a little bit more minor. So what are Parkinson's plus syndromes, and what are the different differential diagnoses for Parkinson's plus as opposed to Parkinson's disease? Does anyone know of any Parkinson's plus syndrome?
I think Dr. Nex and Muhammad Ali does Parkinson's plus, like with the traumatic stress disorder, the concussions or whatever.
Yeah, so repeated like blows to the head or any type of brain damage can cause a Parkinson's plus syndrome. So a Parkinson's plus syndrome is just a collective name for any neurodegenerative disease that causes symptoms similar to Parkinson's disease. So anything that can cause tremor, dementia, changes in walking, abnormal postures, respiratory dysfunction, stuff like that. So the differential diagnosis would be, it essentially means that we need to distinguish other disorders from true Parkinson's disease. So we need to make sure that this is not actually Parkinson's, it's just something else that has very similar symptoms. So red flags that indicate a differential diagnosis include early postural instability, very, very rapid progression, respiratory dysfunction, abnormal postures, uncontrollable, inappropriate laughter or crying, and then any signs of cerebellar, corticospinal, or gaze dysfunction. So some examples of Parkinson's plus syndrome include progressive supranuclear palsy, dementia with Lewy bodies, and multiple system atrophy. So progressive supranuclear palsy, or PSP, is the early onset of gait instability with a tendency to fall backward, axial rigidity, freezing of gait, depression, psychosis, rage attacks, and supranuclear gaze palsy. Dementia with Lewy bodies causes a very early and generalized cognitive decline. You can have visual hallucinations as well as Parkinsonism, so displays of a very Parkinson-esque symptoms. And then multiple system atrophy is a progressive degenerative disease that affects the basal ganglia, the cerebellar, and the autonomic systems, as well as the peripheral nervous system and the cerebral cortex. So pretty much just a general widespread attack on the nervous system. This is the collective name for primary neurodegenerative diseases that cause signs similar to Parkinson's. So you can see that the symptoms within all of these disorders are very, very similar to Parkinson's disease, but they're not actually Parkinson's. So what is Parkinsonism? This encompasses disorders with signs that mimic Parkinson's, but the cause is known to be toxic, infectious, or traumatic. So like Muhammad Ali, repeated traumatic brain injuries can cause Parkinsonisms, but it's not Parkinson's disease. So Parkinsonism is often a side effect of drugs that treat psychosis or digestive problems as well. Drug-induced Parkinsonism frequently leads to misdiagnosis and unnecessary treatment for Parkinson's disease in older adults. So if you are a drug user for the majority of your life and you cause a lot of brain damage as a result of the drugs that you're using, this can often lead to things like dementia and tremors, which would lead a doctor to diagnose Parkinson's disease unnecessarily, even though it's really just a result of drug use. So the signs for this include subacute bilateral onset with rapid progression, very early postural tremor, and involuntary movements of the face and mouth. So just to summarize everything we talked about, 1 to 2% of the population over the age of 65 experiences Parkinson's disease. That seems small, but that's over 1 million people, so it is a lot. Lewy bodies and Lewy neurites, particularly in the substantia nigra, in those dopaminergic neurons that project to the striatum. So these Lewy bodies are just dead, damaged neurons, and they lead to a severe reduction in dopamine levels. This causes a resting tremor, bradykinesia, muscle rigidity. To treat this, we can use levodopa, which was L-Dopa, or other dopaminergic drugs, but there is no treatment that is going to prevent the continuous degeneration within those nerve cells. So regardless of what we administer to these patients, we're never going to be able to get those neurons back. You can only maintain the current function that you have. There's also no disease-specific biological marker. So it's very clear that Parkinson's significantly affects the quality of life, and without any treatment, the mean duration of the disease is about 10 years, and the decrease in life expectancy occurs after about 6 years following diagnosis. The very interesting thing is you're only ever diagnosed with probable Parkinson's until after death. If you allow it, they will take your brain and they'll slice it up and they'll look for these Lewy bodies. And if they find them, they'll diagnose you with actual Parkinson's. So you can't really truly know until after death. So this is your tutorial assignment. The first question, what part of the basal ganglia manufactures and supplies dopamine? So we talked about that. What part of the basal ganglia serves as a primary output nuclei? And then the 5 signs and symptoms of Parkinson's. So all of that can be found in the slides, and the recording will be posted if you need a little bit more clarification on those things. Other than that, good luck on all of your final exams, and good luck with the rest of your degrees as well. Okay. So this was actually the last tutorial, so there won't be any more.